Mentoring with Geraldine is a bite-sized practitioner podcast for naturopaths, nutritionists, herbalists, coaches, and practitioners. This podcast responds directly to the needs of you, the practicing natural therapist. Welcome, everybody, and so pleased that I can bring to you today Tara Nelson. Now, I've known Tara for a number of years now, and Tara is naturopath of almost 30 years, 29 years. And she's her specialist area, or her area that she specializes in, I should say, is thyroid cancers, people, just thyroid issues, all of the thyroid things. Okay. So now you're over in Perth, so it's a nice early start for you.
I'm an early bird anyway, so it's good. All good.
All good.
I'm always up this time.
Thank you everyone for joining us, and thank you so much for coming on today, Tara. Now we were going to talk a little bit about thyroid cancer because I got an email just as I was creating all of this. I'm on your regular email list, and I got an email from you saying, hey, you know how many people have got thyroid cancer? I'm diagnosed every year. And I just thought, oh, what a brilliant thing to talk about, because I didn't realize at all.
No.
I had no clue that there were that many people who were diagnosed. So, can you tell us a bit about, how do people find out? It must take ages.
Well, it's a great way to start, and definitely the diagnosis of thyroid cancers are increasing, and we'll go through in a moment about the types of different cancer. And that's when I started, seeing more presentations in my clinic. I didn't actually realize there were all different types of thyroid cancers with different prognoses and different stats. So we can talk about that. But yes, the incidence is increasing, and usually a cancer will begin in a thyroid nodule. So we can start with how thyroid nodules are really diagnosed, and the majority of them are diagnosed quite by accident. So usually if someone's gone in for a whiplash or even teeth x-ray that goes down to the neck, and someone will go, oh, there's a nodule. Or, I notice quite a lot of the time, many patients will have swollen goiters. I'm always on the lookout for, that sort of thing in my clinic. But most of the time it can be diagnosed quite by accident. But it is really important, I think, to do a thyroid physical examination with our patients. In my level 1, also Katie Randazzo does, physical examination videos. So it's really good I think that really should be physical examination should be part of our workup of every single patient, because thyroid nodules are super common. Many people have them. They increase with age. They're more common in women, and only about sort of 7 to 15%. And that's a new stat that I recently found. It was about 5% were malignant of normal thyroid nodules, and now it's increased to up to 12%. So that was quite alarming when I saw that stat fairly recently. So a nodule will be discovered, and generally if we discover we can feel, palpate in clinic, the next step will be thyroid ultrasound. And then on thyroid ultrasound, they will find certain characteristics of that nodule that will show, yes, it's actually benign. It's called it's a thyroid system, and it's a score of like 1 to 6. And they look at the characteristics, they look at the margin, the size, the shape, what's the sort of ingredients inside the nodule, like calcifications, is it solid, is it cystic? And that'll give it a score. And anything above a 4, usually next step will be a fine needle aspiration. So they'll go in and have a biopsy, and then the cytology from the cells will kind of, again, most of the time, but not always, will show, okay, yes, we've got some malignant cells. It'll show what type of cancer it is. And then the next step is usually thyroidectomy. So, but a lot of those, about 35% of nodules biopsied are actually indeterminate. They can't tell whether they are actually malignant or benign. So it's like, well, we don't really know. And usually then that patient has a watch and wait. Let's wait 6 months, and then let's do it all again. We'll do ultrasound or a fine needle aspiration via ultrasound. We'll see if that nodule has changed in size. We'll see if we can get some more cells. It really depends on the practice or the surgeon or the endocrinologist that they're seeing. Sometimes, even if an indeterminate nodule, they'll say, you know what, we don't know what it is. Let's just go and have it removed, or thyroidectomy. And I've had many patients that have come in and said, I had a thyroidectomy, and from the cytology report post-thyroidectomy, because obviously they can cut it out and dissect the thyroid, many patients have actually come and said there was actually no thyroid cancer there, but I had my thyroid removed. So it is a little bit of a frightening thing. I find with my patients that come in with those indeterminate nodules, I sort of say, well, I think that's a good sign, because we can actually come in, we can support your body, we can, look at the drivers and triggers of nodule and thyroid cancer development, and then let's see if we can make some changes within a 6-month period, which can be, really helpful to that patient. But I feel our role as practitioners in in this space is to really support their journey, to offer options, reassurance, and support. I think it's really important to be able to look at an ultrasound report, look at a cytology report, and, you know, give them support and options. And I feel a lot of, because we're not going to really be treating thyroid cancer. We don't treat unless you are in that niche of cancer, but most, you know, thyroid cancers are the most treatable cancer because of that thyroidectomy. You know, 9 times out of 10, they will say, well, let's just remove your thyroid, and then perhaps we'll give you a bit of radioactive iodine ablation to kill off any sort of remaining tissue. So it's considered the most treatable endocrine cancer because of that fact. They can get in and rip that little gland out. But I really work with my patients to try and avoid that as much as possible, because, you know, losing that middleman, there's that beautiful relationship between, you know, the thyroid, the brain, the hypothalamus, and the pituitary, and the serum level of thyroid hormones in the body. So there's this constant, beautiful feedback loop that's going on. And when we lose our middleman, or one of our three amigos, as I call it, then people lose metabolic flexibility, and they're going from one world of pain to another. So a lot of my patient clientele is post-thyroidectomy support, because once you've lost your thyroid, you can't make thyroid hormones, so you have to be on medication. And I find too, again, losing that thyroid, the conversion is quite poor in these people. So quite a common issue I see in post-thyroidectomy patients is conversion of that thyroid medication they're taking to the active T3. So it's a really because again, they've lost that whole beautiful feedback loop, metabolic flexibility. So let's sort of dive into the types of thyroid cancers. So there's 4 main types. We've got papillary, which is probably 85%, and that's diagnosed in quite young women, maybe it's 20s and 30s. And I have to say that I've been seeing the increased incident of young women, you know, 25, 27, 21. I had a lady the other day diagnosed with papillary thyroid cancer. So 85% is papillary. It's actually one of the best cancers, thyroid cancers to get. It's got a really good prognosis, unless it's not caught, you know, till very late. Its propensity to spread and metastasize is quite low, so it generally has a fairly, you know, good prognosis. Thyroid nodules, thyroid cancers are more common in women, so we're going to see probably, you know, much more women. And like all thyroid conditions, it's mostly in women. We get all the good stuff, don't we? So what else do I want to say that? And there also is, interestingly, a correlation between Hashimoto's and papillary thyroid cancer. So it is one of the risk factors. There's quite a lot of research out there around Hashimoto's being a driving factor. So again, really important to do that physical examination. Always when I'm seeing a new patient with an autoimmune condition, particularly Hashimoto's, I am always referring for a thyroid ultrasound. Like, it's one of my part of their workup, as well as the full thyroid panel, antibodies. I always want to see, particularly if they've had high TPO antibodies for many years. You know, I always say, have you ever had your thyroid ultrasound? And many of them don't. So I, you know, always refer for a thyroid ultrasound just to rule out thyroid nodules. You know, if we can come in and pick up any type of thyroid cancer, then, you know, we're on the forefront of supporting that patient. Yes, so let's do that. Something just popped into my head then, it just popped straight out again, which is quite common these days with menopause, perimenopause. So the next sort of one is follicular cancer, thyroid cancer, and that's about 12%. That's the next common, and that's more common in that 40 to 60 age bracket. It has more chance of metastasizing to the lungs and the bones. And again, Hashimoto's is a driving factor there. So it all depends on those cells that present in that FNA of what they see. So it'll show follicular cells, follicular cancer. It'll show papillary type cancer. So the third one is something called Hürthle cell, and I have seen quite a few cases of Hürthle cell. It is considered quite rare, though I have seen, I remember when I started my thyroid journey, I had a presentation of Hürthle cell he was a beautiful man. He was a Buddhist. He meditated, you know, 2 hours every day. He was super healthy, and yet he presented with Hürthle and wanted to know his options. He didn't want his thyroid removed. And this is many years ago, I actually had to contact someone in our cancer realm, in our patient practitioner world, and say, have you ever heard of Hürthle cell? You know, he just said, yes, it's actually quite aggressive. This is before I went down the thyroid cancer route. It's aggressive and quite rare, and it needs to be thyroidectomy. So I had to come back with him. His daughter was actually a nurse, and she said, Dad, you've just got to get it removed. And him being his sort of lifestyle, he went and had that removed, because again, that one has the propensity to spread quite quickly. Interestingly, also, that tumor, the Hürthle cell carcinoma rather, is it doesn't take up radioactive iodine. So some cancers don't take up iodine, others do. And this one in particular, radioactive iodine ablation is not an option. So thyroidectomy, patients will go down that path. And our last one is called medullary thyroid cancer. And this one is quite aggressive. I remember seeing a patient in clinic. She was actually a practitioner. And she was sort of talking to me about her swollen neck. And I said, you need to go and have an ultrasound. Within, I think she had an ultrasound the next week, they detected a medullary, and it's also picked up in the top half, in the medullary path of the top half of the little butterfly, the little wings. So she had a nodule up there in the top half. She had an FNA, and they found out it was medullary thyroid cancer, which is very aggressive. And she was off for total thyroidectomy removal within the next week. Like, it was like, bam, I've never seen anyone, people move so fast. So that one, again, is very aggressive. Interesting, this cancer affects the production of calcitonin. So we can actually see, if you see a high calcitonin on blood tests, that can be another sort of red flag of actually medullary thyroid cancer. Wow. So something to sort of look at there. So that one is quite aggressive. It can spread to the lymph. Luckily, this was caught just in time. It hadn't actually spread. She didn't have to lose any lymph nodes. She didn't have to have chemotherapy. But yeah, it's really important, I think, if we can physically exam our patients. I mean, you can do it sort of online as well. You can get them to look up, you can look for any swellings, ask them the questions of, do you have any difficulty? Do you have a hoarse voice? Do you have any difficulty swallowing, speaking, any sensation in that area? So they're sort of our main types of thyroid cancer that we may be sort of coming across in clinic. Again, it is not really up to us to treat that thyroid cancer. As I said, most will be removed. We'll talk about some options in a moment, but it's really, when I can see a lot of patients will bring their ultrasound report and I'm up for thyroidectomy. And if you can say, well, actually, you've got Hürthle cell, this is a very aggressive, you do need to do this, come and see me post thyroidectomy, and we're going to support your body metabolize that medication really well. We can support it. And there's different medication options around now that we also have to support those patients, which is, being on the forefront of that is really, they love that. Patients love that. So we can also see cancers that metastasize to the thyroid, so it's not uncommon. So some cancers, including breast, colon, renal, and melanomas, can actually are known to metastasize to the thyroid as well. So we can have other cancers of the body that actually affect or cause, or metastasize to that thyroid as well. So there's many causes of thyroid cancers, and it's important, whether they've had whatever treatment they've had. Of course, we're going to look at those root driving, reasons why. No matter if they've had, the thyroid removed or they've had radioactive iodine, when they come back to me, I'm always like, well, what was happening before? Let's look at, do you have Hashimoto's? We still can treat Hashimoto's whether they've got a thyroid or not. But many causes include, obviously genetics, radiation exposure, particularly in childhood. So I'm always asking about where they lived, if they were from a different country, if they had a lot of x-rays. So kids that have, damage or accidents or, spinal issues or anything like that. Some children do have a lot of x-rays, particularly for their teeth as children. And you imagine dental x-rays, that is right near the thyroid. I always tell patients if they're having any x-ray, is they can wear that as a guard. I can't remember what it's called off the top of my head, but it's a guard you can actually put, and most dentists will have it. I remember having a lot of dental work a few years ago throughout COVID, and I always wore that guard over my thyroid. So most dentists will have that guard to protect that gland. So it's really important. So any of us, if you're having an x-ray, make sure you ask for that guard. Women, obviously, is increased risk. Increasing age increases the risk of thyroid cancer. Iodine deficiency and excess as well. We've talked about thyroid antibodies. Obesity is a driving factor. Insulin resistance, metabolic syndrome, heavy metals and toxicity, and inflammation as well. So as I said, thyroid cancer is considered to be the best, has best treatment success because of that, they can remove it. And as I said, most thyroid cancer will be that thyroidectomy, especially that Hürthle medullary, because they are aggressive and spread and even follicular. But sometimes I'm also working with patients when they're up for thyroidectomy. Can we just, have a partial or something called a hemithyroidectomy? So we can preserve that other half of the tissue. So that, I do have patients that have had a hemithyroidectomy, so only one butterfly wing removed. And that other half can actually still produce enough thyroid hormone so they don't actually require medication. So that is the best case option. So talking with the patients, going over their options, because many surgeons will just say, just get it out. You don't want it, you don't need it. Why would you want it? Your cancer might develop in that other side. So, I'm always talking about, if we can preserve that thyroid tissue, you're going to be a lot better off. So just something I'm not sure about our time, but something to consider there is a procedure called radiofrequency ablation, which is a fairly new procedure that was brought to Australia by, her actual name is Professor Catherine Sinclair. She's an endocrinologic surgeon working out of Melbourne, and she travels to Sydney. I learned about radiofrequency ablation many years ago and it was only in America, and she's actually brought it to Sydney. So some patients firstly, when it came out, it was for benign thyroid nodules. Now we can actually use it for small papillary cancers. So there's obviously criteria. So just for instance, a radiofrequency ablation, it's done under a local anaesthetic. They're actually doing it at Fiona Stanley in Perth now. They're the only 2 places in Australia that I know that are doing it, but it could be more by now. And it will spread. There'll be many more places. So basically, radiofrequency ablation under a local anaesthetic goes in with a high heat probe, and it actually zaps the nodule and it sort of kills the tissue. And then the immune system over time comes in and actually eats that tissue. So just for instance, I had a patient that came to see me, and we discovered that she had small papillary thyroid cancer in one nodule on the right side and a benign thyroid nodule on the left. Now, she was from Sydney. She got a referral from her GP to go and see Catherine in Melbourne. And Catherine sometimes wants further testing, maybe in more FNAs on those nodules, but she was a candidate for radiofrequency ablation. Now, she was up when she came to see me, she was up for total thyroidectomy. She had thyroid cancer on one side, benign nodule in the other, and her endocrinologist said, here's the surgeon's details, you need to go and have your thyroid removed. She came to me, I put her in touch with Catherine. She flew to Melbourne, had radiofrequency ablation. I think she flew back the same night. Now, within 12 months, I've been following her and actually include her as a case study in my level 2 training, because we talk about all these things. She no longer has thyroid cancer. She no longer has thyroid nodules, and she has saved her thyroid. This is something when we can, and you can imagine she's over the moon. She saved her thyroid. So again, having this knowledge that we can actually share with our patients, hey, there might be another option for you. And obviously there is criteria. I've got a patient at the moment that has quite a large nodule. We're just hoping that can be zapped with RFA, but we don't know, and we won't know until she goes and sees Catherine. The other sort of advancement in this space also is something called molecular testing. And as far as I'm aware, it's only done at Monash University at this stage, but that's really helpful for those indeterminate nodules. So as I said before, when a nodule is detected on thyroid ultrasound, then, if it has those certain characteristics, a triad 4 or above, they might go in with an FNA and they take some cells out, and around 35% of nodules come back as something called indeterminate. They can't tell whether it's benign or malignant. Now, I always say to my patient, I feel like this is a great sign. Come to see me. If we've got 6 months, because they're going to follow you up in 6 months, we can work on all those kind of, cancer kind of causes, drivers, triggers. There's many sort of treatments that we can offer to reduce nodule size, make sure that your health is in the best place, and then let's see what happens at that next FNA. So another sort of procedure, as I said, that's just come into Australia out of Monash, and I've got a patient actually going through it. It's quite expensive. I think it's around $2 to $5 grand to actually have this one test. But what they do is they put up your DNA against, so they take a sample, obviously, of your DNA, and they put it against known kind of thyroid cancer or cancer oncologic genes. And if you're a good match, then they'll go, well, actually, yes, your genetic testing profile shows that you are at high risk for developing cancer. Let's do that thyroidectomy. So, or no, actually, you've got no oncologic genes in your body. We're actually we'll just keep watching and wait that and maybe see if there's any changes. So again, there's new advances in this field that we can actually support our patients with, and it's really handy to know those sort of things.
Wow, that is amazing. I've just been blown away, and so has everybody else in the chat. It's just, wow, it's coming up. So there is so much learning here from you. I mean, you've got your level 2 training, which has opened up, and
yes,
that means
start on the 20th of May. We're doing level 2.
20th of May. I mean,
yes.
that's really close.
Yeah.
And it's amazing. I've done your level 1 long ago, but I did your level 1, I think, the first time it came out.
You did,
and,
yeah. Long ago, 7-8 years ago, I think that was now. Level 1, first level 1. And that time gone, Geraldine? Oh my goodness.
Where has that time gone? And so much has changed since then.
Yeah.
There's so so much more.
Absolutely, it has. I've rewritten level 1. I've re-recorded it because, again, of all those changes. Level 2 is still fairly update, and I can keep up with those changes when I run it in the group. But I was actually thinking the other day, do you know what? I'm seeing so many new reading so many research studies on this sort of space that I feel like it's level 2 is coming up for a rehash, probably in a couple of years, not quite yet, but there's just so much, and it's great. Finally, we're getting some new advances in thyroid health, because there's not a great deal that goes on in this space.
No, it's so good. I mean, that's mind blowing. Everything you've talked about is mind blowing. And now confident practitioners who have been seeing people and seeing thyroid patients, they can join your level 2. They don't have to do the foundations course.
This is the first time I'm offering this. And normally you have to do the foundations course to do level 2, but I do get asked by a lot of practitioners. I feel pretty confident about the identification and assessment and treatment, but I really want to learn about thyroid cancers, how to identify, looking at thyroid ultrasound reports, really diving deeper into that thyroid knowledge for level 2. So it's a much more comprehensive course. If you did level 1, this is a lot more information, a lot more intensive, but for those thyroid practitioners that feel quite confident in thyroid health, and there's many out there, then I've opened up level 2, yes, for this round. And we'll see how we go.
Katrina says, I did your level 1 version 1 year ago. Great info. So, I mean, they are good. And they're fantastic stuff, because there's a huge, it affects so many things, as you said, it's
100%. And it's complex. It's complex. Thyroid physiology is complex. And that's why when I started seeing so many thyroid presentations in clinic, what we were taught very briefly, in college or whatever, was like, I was looking at their symptoms, looking at the pathology, going, this does not add up. I was presented with extreme, very chronic Graves cases. I was presented with, thyroid cancers, and I don't know what I had to do. So I had to throw myself into research too. And then I thought, well, there's this big gap in practitioner training in this area, and it's complex, it's evolving, it's changing. So it's, and it's so common, I feel like, and the whole reason I sort of started, I was thinking about it this morning, was because when I got my own thyroid diagnosis and then my daughter's diagnosis after, I thought, I've been walking around with Hashimoto's for how many years and I didn't know it. Same probably with my daughter. And how many women are walking around? How many women are walking around with a thyroid nodule and they don't even know it? And that is super common. Usually, like I said, it's discovered quite by accident many times. People go, oh my gosh, I've got a thyroid nodule. Yeah.
Really interesting. You watch TV. I was watching the news the other night and I was like, do you put on Twitter to these people, mate, you need to get your thyroid checked because that neck isn't right?
Yes, I'm constantly looking at necks and eyes, bulging eyes. I'm constantly looking out for thyroid eye disease, TED. I look at people and go, oh goodness, you've got Graves or you've got TED. Yes, in the supermarket. Or loss of their eyebrows. I saw someone the other day, this guy I was at the checkout with, and he had literally the loss of 1/3 of his outer eyebrows. He had no half, and that's a thyroid sign. And I was just, do I say something? Can't say something to a total stranger. But yeah, it's interesting to be aware of these things.
Yeah, I had years ago now, I went for eyebrow, to have them sorted, plucked, that's the word.
Yes.
And she waxed them, and she waxed the outer thirds off, and because I've got a scar. And I was like, you can't do that to people. And she was like, no, it's really trendy right now. I was like, it's not trendy because it's actually a medical sign. So do not do that again. And she was like,
what's trendy to wax off 1/3 of your eyebrow? I mean, what trend is she following? I know eyebrows have gone through a massive weird trend, but that is crazy.
It was a few years ago, and I had to explain that, no, you cannot do that. So
exactly.
As we said, now we haven't got much longer. Now, everybody in the chat, you need to write, if you want a CPD certificate, you have to write Tara in the chat at the end here, so that my VA will possibly contact you checking that your full name is correct before she sends you a CPD certificate. So you need to write Tara in the chat so she can go through later to get that CPD certificate. And they're all just Tara. And
a great way to get CPD.
Somebody, their association, it's the May something or other. I'm like, well, let's just do this, because then everybody for their association.
Good idea. Yes, perfect.
So, but your level 2 starts May 20th, and obviously you do it once or twice a year. the level 2?
I usually run my level 1 and level 2 twice a year. So in the first half and the second half, I've just finished the level 1. I'm hoping to run level 1 again. I'm really not sure about level 2. I have quite a lot of presenting commitments and traveling for them in the latter half of the year. So I'm not committing to another level 2. So at this stage, I'm saying this is it for the year. I just don't want to put myself under pressure. So yes, I may, but I probably won't.
And
so
you've got a little bit of a discount, I think you said.
Yes, yeah. If you type 15 into either the full payment or the payment plan option, you'll get 15% off.
There you go. So promo code is 15.
Promo code 15.
15, you'll get 15 off. So that's really cool for those of you who want to do the level 2 starting on the 20th. So thank you so much for coming on. That was
welcome. Thanks for having me.
Of information. So happy. Thank you so much for coming in and talking to us. And thank you everybody for joining us. And we'll look forward to seeing you. I'll see you all tomorrow. Same time, same place, same bat channel. See ya.